I'll now request Milind and Dr. Gupta to come for the next session, and this is really the most futuristic, the role of artificial intelligence in cardiology.
Good afternoon. We come to a very exciting session. We are all now increasingly hearing these terms: deep learning, machine learning, big data, and successive iterations of artificial intelligence are coming up. We are seeing papers being published, and some of these advances have now washed up the shores of Mumbai city also. And there is no better person than Dr. C.K. Pondesu, who has actually been involved in trials of AI, to talk on this. So, sir, please enlighten us about AI in cardiology.
Thank you very much indeed. Thanks to Milind and Dr. Sharma, Dr. Pailajani, Dr. Anil Kumar, Dr. Gupta and all. They have been all my teachers, and here I'm almost feeling that I'm presenting a case in front of Dr. Satyavan Sharma, you know. So I'll start. Artificial intelligence in cardiovascular medicine, will it change the way we practice? What is artificial intelligence? Just for the beginner, artificial intelligence is a process of unifying mind and machine through human brain and computer interfaces. The term AI was first coined by John McCarthy in a conference on science and engineering of making intelligent machines in 1956. So AI in healthcare is indeed unifying the mind with the machine. In other words, artificial intelligence is the theory and development of computer systems able to perform tasks that normally require human intelligence, such as visual perception, speech recognition, decision making, and translation between languages. But now it has gone one step further. It also is willing and able to do the task beyond human intelligence. And that is what I'm going to show you today. This is how we used to examine the patients before. This is a physician who is to keep on looking at the patient, feeling the pulse, watching the breathing, watching the pallor of the face, and probably even smelling the breath to get a diagnosis. And at the backdrop, we will have his assistant sitting in shadows, watching the patient and the physician in case they are missing something. And now we have artificial intelligence taking that spot. So it's just simply you are changing your assistant. So I will frame my talk: AI, the good, the bad, and the ugly. Do we really need AI in cardiology? Yes, of course. Cardiology practice is becoming more and more complex. We have humongous amount of data to dissect and use it in clinical practice. Humans and we, cardiologists, are all about images. Ashish had shown several images of the leads, angiographic images, echocardiographic images, and so on. But humans take images as a series of photons into the retina and perceive them through visual system, and some information may be lost in this process. AI models can directly perceive raw data as it is, without any loss, without bias, and without noise. Bias is very common amongst us. For example, if I see an echocardiographic image versus my student sees the echocardiographic image, it's a difference. Same way, by combining different inputs of data, it is possible for AI to discover a totally new relationship between that image and the clinical scenario. And I will show you the how. So we have now AI well established in valvular heart disease, coronary disease, heart failure, atrial fibrillation, and congenital heart disease. So what is good? Natural history of the disease, the metabolic and abnormalities start over years, but you feel great, and suddenly symptoms begin. By that time, it may be too late, because your first manifestation of the disease could be stroke, heart attack, or even sudden death. So is the ejection fraction low? Heart failure. So single heart cell has a voltage, and ECG combines that voltage into an electrocardiogram. And then the Mayo Clinic group was the first group. The Paul Friedman, Adria Gitia group came forward, feeding millions and millions of people's ECGs to the machine learning algorithm over a period of years. People with low ejection fraction, mid-range ejection fraction, normal ejection fraction, and high ejection fraction. And they got the receiver operating characteristics area under curve of 0.9. Just a sinus rhythm ECG to predict ejection fraction. I will show you a case here. These are the two biggest algorithms in place. the ATIA algorithm from Mayo Clinic, and the Carter and Patrick Johnson's algorithm from the another group. This algorithm, when used in the emergency department, for varying group of patients, patients coming with sepsis, breathless, non-breathless, a single ECG will tell you which patient is likely to have a low ejection fraction. And it has outperformed NT-proBNP in this wide clinical trial. So this is the case, 35-year-old asymptomatic man presents suddenly after his sister dies. Standard ECG, computer says it is normal. AI ECG says 76 probability of low EF. Echocardiogram, low EF. Going ahead, a 28-year-old male, look at this weird repolarization abnormalities. ECG computer labels as abnormal. AI ECG positive for low EF. So ordered an echocardiogram, but echo shows an EF of 50%, false positive. 5 years later, the same man has an ejection fraction of 31%. This is for Mayo Clinic group. So what is important is those people who have an AI ECG predicted normal EF, only 10% of them develop low EF over a period of next 5 years. Whereas when the AI had said poor EF, and at the index time the EF was normal, as many as 1/3 of them develop low EF over the next 5 years. So what is important here is every single myocardial cell has a signature on the ECG of future development of poor EF, which you and me cannot read, but AI can read. That is called deep learning. So you have prediction of disease of patients with high risk. So the same algorithm now on an ECG was adapted to primary care, and what it showed, that high adopters had more chance of detection of poor EF than physicians who did not adopt the AI ECG. What about smartwatch? Imagine this is about ECG. So the patient has to come to the hospital. What if a smartwatch ECG can do the same? How scalable it will be? It can apply to a large, vast number of population. And then this paper published just 2 years ago, prospective evaluation of smartwatch enabled detection of left ventricular dysfunction in the ESC 2 years ago. And again, it can be done by just a smartwatch. EAGLE was a randomized trial. Now those of you who want evidence-based answer, randomized trial. 22,000 patients, 8 months, 120 care teams, AI predicted EF of 32%. Resources well allocated. Top of the license care well allocated. Meaning, if you do an AI ECG, you can order your echocardiograms in a choosy manner to those AI ECGs which are predicted poor EF. Again, ECG guided AI, the EAGLE trial, again well discussed, well appreciated. So can the clinical practice be modified? Certainly. You will start looking at ECGs in a different way. Question is, do I believe it? What is the financial structure and what's the access? Access will become more and more as we go farther. ECG prediction of biological age and sex? Are you kidding me? But yes, it is a reality. Social isolation, acute illness, obesity, chronic illness, low ejection fraction, they all increase your biological age. So this algorithm, again by Mayo Group, trained the AI with a humongous 5 lakh and odd patients data. The data was buried with machine learning for 3 years and the deep learning for another 1 year. And what it came up with? Biological age versus chronological age, area under curve 0.97. I will show an example. 35-year-old woman presents to the cardiovascular prevention clinic. She is obese. AI age was 40 years. So biological age 40 years, chronological 35 years, wide gap. So she was investigated. CT coronary angiogram was done, CT coronary calcium was done, 2D echo was done, nothing was found. She was metabolic syndrome, pre-diabetic, obese. So put to lifestyle modification. At the end of next 1.5 years, she lost 10 kgs. AI ECG done again. Now it says biological age same as her chronological age. Look at these two ECGs. They look the same. They look the same. Meaning thereby that every single myocardial cell of you and me has a signature on the ECG of your cellular senescence. You are aging. And now we just come up in ESC this year that any difference in biological age versus chronological age of more than 3 years, the patient needs an echocardiogram, a CT coronary calcium score, and perhaps a coronary angiogram. So this is where we are going. Look at this man. When he presented at the age of 38, the biological age was 54. What he had? He had ejection fraction of 40%, mildly reduced ejection fraction. As years went by, his ejection fraction kept on coming down. At the age of 47, his biological age was 60. Ejection fraction 25%. At the age of 53, suddenly his biological age came down. What happened? He got a transplant from a heart which was 29 years old. So now the signature of that heart on the ECG has changed. Your biological age has come down. Also, retinal vascular network can give you cardiovascular risk. The paper was published from Madurai Heart Institute 6 years ago. And now this algorithm of retinogram or fundoscopic retinogram has been widely accepted for prediction of future cardiovascular risk. This is a change, my friends. Change can be scary. But you know what is scarier? Allowing fear to stop you from growing, evolving, and progressing. Look at atrial fibrillation. We know symptomatic AF is the tip of the iceberg. But subclinical AF is common, undetected, and is a precursor of stroke. So, 3 algorithms have been developed in the world. One from Mayo Clinic, one from the Kentucky Heart Institute, and third from the Canadian Heart Institute. All these algorithms fed data of patients with paroxysmal AF in sinus rhythm without telling the computer that they had AF at all. And another deep learning model, patients who had never had AF, either on Holter or in real life, their sinus rhythm ECGs. These were buried alive in the machine learning for 2 years. Another 2 years deep learning and another 1 year for generative AI. And what emerges is area under the curve of 0.90. So a 10-second sinus rhythm ECG can tell you whether the patient is likely to develop AF in future or had AF in the previous 6 months. And this algorithm is as good as the charge AF score for predictability of the atrial fibrillation. One step ahead. ECG can also tell you left atrial myopathy. So, as the predictability of ECG for AF increases, your left atrial volume increases, left atrial reservoir strain comes down, and mitral E by E prime ratio keeps on going up. Similarly, higher the predictability of the AI ECG for atrial fibrillation, your survival decreases over the next 8 years. And this paper from Verbrugge's group was published in 2022 Jan and has a humongous 1.7 lakh patients. So it's not a small data at all. It's not a data you can dump just because you don't tend to believe it. Look at this data's dissection. As the AI probability of AF kept on growing from 1%, 15%, 67% to 85%, the E by E prime increase, the LA volume increase, and the peak TR jet velocity increase. So that means a simple 12-lead ECG can also tell you whether the patient is likely to have left atrial myopathy, which is a precursor of atrial fibrillation. What about aortic valve stenosis? The algorithm is already in place. Now those who are tower fans here in the audience will be excited to know that a simple ECG can tell you predictability of aortic stenosis. Look at this guy who had severe AS and heart failure and underwent aortic valve replacement in 2019. His ECG 2011, AI ECG, predicted no AS. 2016, 3 years earlier, his ECG had predicted aortic stenosis. But the guy did not undergo echo for some reason or the other, and then underwent aortic valve replacement 3 years later. What is this ECG? This is a clip classic of cherry on top appearance, amyloid. And now, you don't have to do all this because two algorithms, Harman's from a group which has used around 11,000 patients with ATTR amyloid, AL amyloid, and heritable amyloid, has an algorithm in place. A 12-lead ECG can tell you amyloid or no amyloid, with a positive predictive value of 85%, negative predictive value of 99%. So that is where future is. And this is Mayo Clinic's algorithm telling you the same about cardiac amyloid. Look at the area under the curve, 0.92 for ATTR amyloid. What about power of ultrasound, power of AI and cardiac ultrasound? Milil will be very interested in this. For example, this is a patient of mine who came to our consulting room, emergency room, a typical chest pain smoker, 42-year-old. Can anybody see anything wrong in this echo? Milind, can you see anything wrong? I don't think. I labeled this echo as normal. And then Sindhu had sent us this AI algorithm. We fed this ECG to an AI. AI said, patient needs a coronary angiogram, tight LAD stenosis. We didn't believe that. And this is, look at the subosteal LAD, subosteal high diagonal, tight stenosis. The echocardiogram was normal. So what AI saw in this ECG, echo which you did not and I did not. Here is a clip. Kindly have a look. This is a Bond film, a chase. The clip is over there. Now if I ask you, in this clip of 20 seconds, how many umbrellas did you see? How many cars did you watch? How many persons did you see? How many ladies? How many males? How many children? This is how AI does. Man, person, umbrella, chair, person, umbrella, and all that. So this is what AI would be. So AI doesn't look at the image the way you and me look. So at the end of the clip, it has seen a cell phone, it has seen bikes, it has seen everything. And at the end of the clip, it will tell you there were 19 umbrellas in this clip, 18 bicycles, 800 cars, and so on and so forth. So this is a clip of a hypertrophic cardiomyopathy. HepPef or no HepPef, right? You can say yes, most probably HepPef, right? How does AI see this clip? It sees this clip as series of grayscales in the center with backscatter behind the heart and backscatters in the cavity. Right? So this is what AI does, which you and all of our eyes combined can't do, will never be able to do. So image analysis is a core fundamental power of AI. So for example, in my own department, look at this cardiogram, parasternal long axis view. I freeze it, AI goes in action. All that I do, auto AI, it gives you diastolic dimension, systolic dimension. This is Doppler of the mitral. In the olden days, I used to measure E velocity, A velocity, E velocity, A velocity. Now one click, all are average. This is auto EF. This is 3D. I take one image, I get a base view, I just auto LVQ. Look at what the computer is doing. This is on its own. I am not doing it. Base, apex, diastole, systole, tracked, processed, 3D EF, done. 6 seconds flat. So this is what AI has a power. 3D EF of the right ventricle, same way. AI quantification MR, already well established. AI quantification of AS, well established. So, gone will be the days where I will spend 20 minutes in looking at vena contracta, regurgitant orifice area, pizza, jet area versus LE area ratio and so on. You just give 2 images and 2 jets, 1 click, and it will be done. With an accuracy of close to 90%. Yes. A trained echocardiographer will be needed at the end of the day when AI may go wrong. Or your clinical picture and the AI derived analysis does not match. But then time will be saved. Here, look at this. Cognitive machine learning algorithm to distinguish restrictive cardiomyopathy from constrictive pericarditis. Sir, you have been our teachers. And this has been the Achilles heel of cardiology, hasn't it? Restriction versus constriction. We have spent hours and hours learning, digesting, reproducing in front of the examiners and still failing the exam for this reason. Right? So now AI can do that for you. This algorithm is approved by the ESC. So cognitive machine learning algorithm for distinction of CP versus restriction. So artificial intelligence and echo is happening. We brought a software 3 years ago for barely 30 lakh rupees. And today it is paying back very, very well. Look at this. Does this patient have HEPPEF? Single view. So Milind, do you think this patient has an HEPPEF? Okay. Now, I have ultramics in my department. One single apical 4-chamber view can tell me what is the predictive value of this view to this patient to have HEPPEF. And then in that patient, I may spend 10 more minutes getting LA volume, LA strain, E by E prime, at rest, on exercise, PV flow and so on. I don't waste my time. So in echo, it can use for classification, optimization, volume calculation and identification. In cath lab, interventionalists, pre-intervention, intervention and post-intervention. Can AI read an angiogram? Yes. Look at the way AI reads. AI can read from proximal to distal, image by image, fraction by fraction. Predictive accuracy, 90%. So the take-home message is AI can localize stenosis, predict their severity, excellent performance in identifying views, structures, and stenosis. Now, the Philips top of the range lab today and the Siemens both have the algorithm in place. So you don't have to really go by oculostenotic reflex. That reflex will be out of the window in no time. Similarly, what about prediction of left ventricular ejection fraction by left coronary angiogram? For that matter, look at this angiographic picture. Experts can tell you this heart is not moving as well. This heart is moving better. So AI tells you probability of low EF 98%, actual EF 22%, low EF predictability 2%, actual EF 55%. That's that. This algorithm is also in place in top of the range Philips machine today, top of the range Siemens machine today. So artificial intelligence is able to calculate, differentiate patients with low EF from those with normal EF with angiogram alone. And now there are 4 algorithms of FFR in place. These are all AI generated. This algorithm, the fast algorithm, VFFR, will give you FFR by angiographic 2 orthogonal views alone. Sorry, can I take a minute? So, application of AI in cardiovascular CT. CT can also tell you the accuracy with which the lumen of the coronary angiogram is behaving. So these CT pictures have been tallied with the OCT. And after deep learning of over 8,000 CTs, precise lumen analysis was obtained just like OCT. So AI is going in a big way. Now robotic angioplasty will come. We'll have future cardiac cath lab with AI-enabled technology, clinical decision support systems, voice-powered catheter movement, and even a virtual hologram. In just finished Eco India conference in Westin, we had a guy from Greece who showed us this hologram coming right in front of you as a virtual image, and you can maneuver the catheters inside. This is the latest news. ChatGPT takes on European board exam and passes with a score of 75%. So there we are going. So soon, Dr. Sharma may not be asking you questions about why the A wave in the right atrium is taller than the A wave in the left atrium. No. The question could be, which AI algorithm is better to diagnose hypertrophic cardiomyopathy by resting ECG? Or which AI algorithm is better to calculate the predictability of constrictive pericarditis from one single echocardiographic image? Look at the money involved. $11,820 million by 2025 in AI. So we are at this stage right now. Soon we'll be with mass adoption and then maturation. Microsoft buys AI firm Nuance for $16 billion for healthcare business. The bad part, AI does not know reasoning. AI doesn't have consciousness. So reasoning, leave it to us. Technical help, take from AI. Another problem, bias. Because AI ultimately feeds on the data. And most of the data in RCTs is extremely male and extremely white. So you will have problems about bias against women. The ugly part, the data that you give can be hacked by the providers, like Microsoft, like Amazon, or whatever. And this data can be used for wrong reasons. So, Ultramix, the AI that I'm using in my lab, look at the latest news. 2023 works alongside Medicare and Medicaid services, insurance companies. So those, if they combine with AI agencies, can possibly start dictating terms to you. Elon Musk just said, scientists only have 20% chance of being able to make AI safe. But potential of AI is indisputable. The question is how to integrate it successfully in our systems. For doing so, we have to overcome technical limitations, regulatory obstacles, ethical concerns, and curb the tendency to oversell the technology. The biggest fear, will AI replace medical professionals? The dark side. This I call the really dark side. And each one of you will be afraid where AI will replace you. The answer is very simple. Neither the man nor the machine can replace its creator. Have we been able to replace God? No. So AI can never replace us. Thank you.